Thank you, Prof. Eugenio. Can you hear me? Can you see my slide?
Yep.
Yes. Okay, thank you. Because this is a common question that we need to ask during visual webinar, right? So basically, my thought is on the impact of COVID-19 on cancer screening. And my colleague just now cover more on oral cancer, but I will be cover more on colorectal cancer, breast cancer, and cervical cancer. So before I go further looking into what is the impact of our cancer screening, of course, we need to see the COVID-19 story first, what happened actually in Malaysia. And if we can see here, this is the story of COVID-19 in Malaysia in 2020. So basically, unfortunately, the first cases actually started on 25th January 2020. And at earlier phase, we can see that the digit or the number is actually starting from 1 and increasing into 2 digit, become 3 digit. And during at that time, we have a few of movement control order, and until this year, actually, we have another third wave. So basically, we have first, second, and third wave of COVID-19. Until on 20th of September, we have another wave of this COVID-19. And this is actually the overall of how the Ministry of Health, in view of the public health, respond towards the COVID-19 pandemic. And by looking into this graph, we can say that we have actually third wave. The first wave, actually, the cases is not so much. This is the second wave, is starting to have a higher in number, but in third wave, is actually the number is become until 10,000, 50,000 into 20,000, which is actually really bad. And looking into this figure, we can say that because of the higher cases during the first wave, the government started to have a movement control order, the first one, and then follow in the after the second, actually we started to have the second movement control order, and again another MCO3 on the 12th May. So if we compare our cases of the COVID-19 in between neighborhood country, we can say that cases in Malaysia is still higher as compared to other neighborhood countries like Thailand, Indonesia, and Vietnam. Nowadays, the cases for every day is actually about 5,000, and most of the cases of the COVID-19 actually affected among the age group of 80 to 59 years old. And we have achieved more than 90% of the vaccination. And we also have started already for the vaccination among the adolescents, as well as the booster dose. And we hope that by having, by increasing trend of the vaccination status, this impact actually lesser for the cancer screening impact for this year. So let's look into the cancer trend in Malaysia. So as we know that the top 5 of the causes of death in Malaysia, actually one of that is actually cancer. And if we would like to see on the most common cancer, for a comparison between data of 2007 until 2011, and another set of data is 2012 into 2016, we can see that the highest number 1 is the breast cancer, followed by colorectal cancer, and the third one is actually lung cancer. And looking into the comparison between male and female, the female, of course, the breast, colorectal, and cancer cervix. And for the male, is actually the colorectal, followed by lung cancer and prostate. And most of the patients who have this type of cancer coming to the hospital or clinic at the late stage. And because of the late stage, they have very poor survival. And as we can see that for the breast cancer, the survival rate is actually only 23%. The colorectal cancer for the stage 4 is only 70%. And for the cervix cancer, 23%, as well as for the lung, which is only 6.3%, which is very low, very poor prognosis. So basically, previous speaker did mention that Malaysia is actually do not have organized screening program, but we have actually opportunistic screening. So for example, for the colorectal cancer, most of FOBT has been offered in government primary health clinic. And the case, this screening actually been offered for the 50 years and above only. For the breast cancer, beside the Ministry of Health, the Ministry of Women, Family and Community Development, and some NGO did offer the breast cancer screening. And for the breast cancer, for the mammogram screening, actually in the development of structured mammogram screening program for the high-risk women. And for the cervical cancer, beside our government primary health clinic, also other sector coming from the Ministry of Women, Family and Community Development, NGO, also did offer this pap smear. And we also introduced starting 2019 that the self-sampling of HPV testing, but this one is actually very limited to certain clinic only, not thorough in the overall of the Malaysia. So this, let's say the cancer screening status. So what is actually Malaysian status before COVID-19? As we can see from the report of National Health Mobility Survey and the article published by Aruna, we can say that the screening uptake is still low. As we, if you can see here that for colorectal cancer screening in 2018, only 0.68% underwent IFOBT screening, and among those who are positive, only 55.2% underwent colonoscopy. For the pap smear, is only 36.6% undergo pap smear, which actually we still did not achieve the WS strategy, which aim at the 70% of women screened at the age of less than 35 and re-screened at the age of less than 45. So what about for the breast cancer? Is basically 21% underwent mammogram within 3 years, and 25% underwent mammogram for the lifetime. So looking into this, we can say that before COVID-19 itself, the screening uptake in Malaysia is very low. So what about during the COVID-19? Of course, it's actually coming down also, but we don't have any exact number as we do not have a very systematic data collection for this screening status. And more of the healthcare provider, actually the pandemic COVID-19 is actually the prioritized as compared to chronic disease like to screen for the cancer. And the cases of the screening uptakes actually the impact actually depends on the locality of the hospital or clinic involved in the pandemic COVID-19, because some of the area of the COVID-19 can be at the red zone, some can be at yellow zone, some can be at green zone. So the locality of the clinic or hospital also actually depends on which area of the COVID-19 zone, and this also will affect the screening status during this COVID-19. And of course, I did show that because we have first, second, and third wave, and we also that leads the government to enhance the movement control order, also reduce the trend of people of population to go for the screening. Looking into the factor itself, the first one I can say because of the screening system itself. Before this, the screening actually is opportunistic. Patient come to the clinic, the doctor may offer for them to do a screening, but during this pandemic, it's actually by appointment only because of the restricted movement. And for the patient itself, because of the pandemic COVID-19, their fear is actually increasing. They are afraid of COVID-19, so they only come to the clinic when they are sick. And most of the patients actually refuse to wait for the screening because we need to offer, and then we need to have some procedure, right? So they are refused to wait for the screening. So that actually leads to the reduced number in the screening uptake during this COVID-19. And among the doctor itself, the healthcare provider, the screening of for the cancer actually is not an emergency procedure. And the priority is actually more towards the patient who come in with the symptoms of COVID-19. And if let's say patient come in with a symptom for the cancer, then there is a priority there. So from here, we can say that before and during COVID-19, it become worse during COVID-19 of this screening update, but the trend actually still in low percentage. Malaysia has come up with a national strategic plan for cancer control program for 5 years. This is actually the new one has been launched for this year. And this cancer control program is actually 2021 until 2025. And in this cancer control program, one of the objectives is actually to strengthen early detection of the cancer. And I did mention that most of our people come at the late stage. So that's why the overall target is actually to downstage the breast, colorectal, and cervical cancer at the time of diagnosis by 20% by the year 2030. And the main strategy beside prevention, promotion, diagnosis is actually screening and early diagnosis. And this is actually the one that mentioned in the cancer control program. For the colorectal cancer, any asymptomatic individual aged 50 to 70 years old, they will offer FOBT followed by colonoscopy if the FOBT positive, and the screening interval is actually every 2 years. And for the cervical cancer, all sexually active women aged 30 to 65 years, they will offer HPV vagina sample, whether they can do by themselves or by healthcare professional. And the interval is basically 5 years for HPV negative. For the breast cancer, the clinical breast examination supposed for the age of 20 to 39 years old every 3 years by trained healthcare professional. And if the woman is more than 40 years, it should be annually. And for the mammogram, the age more than 40 years with risk factor should be done every year. And for the age of 50 to 74 should be done for every 2 years. Just to highlight a little bit on my research on colorectal cancer, since my interest more on the colorectal cancer screening, we did publish some of the data in the northern part of Malaysia, and looking into the rate and what are the associated factors towards the FOBT, and we found out that it's only 32. We found out that 32.2 actually refused FOBT even though it has been offered. And what are the factors is actually the higher risk group, which is a smoker, patient who have diabetes, hypertension, and then the patient who do not have symptoms. And physician recommendation actually give a higher risk for them to go and for the screening as compared to medical assistant and the nurses. And what are the reasons actually they refuse this FOBT actually because of no awareness in view of they are really not ready for the test, feeling healthy, having difficulty with transportation, having a busy life. Looking into this reason for refusal, we can say that the awareness is still low, and they are not think that cancer screening is actually one of the priority in their life for them to look into whether they have a risk for cancer or not. And because of that, because of the low awareness, we proceed to develop a media to promote, to give awareness, to motivate the patients population to do these screening updates. And from our meta-analysis, we found out that the e-media actually give a positive in view of a favor towards the uptake of colorectal cancer screening. Therefore, we come up with DevOps, a decision aid video on CRC screening. And this DevOps actually, we are tailored to the Malaysian populations, and we are focusing more towards the justification, the problems for them to let them know the importance of the early screening. And in this video, actually, we try to reduce we are more toward the motivate, not to fear the patients of the population. That's why we end the video with a happy ending, and they survive due to the early CRC screening. And in this study, actually, is still in progress, and we would like to see whether this community intervention able to prove the effectiveness of the awards in view of the awareness and the screening updates. We also, my research team also would like to see what is the patterns of CRC in Malaysia, and looking into the data that we have from the National Cancer Registry from 2006 until 2016, we found out that there is some patterns there. There is a cluster of CRC at the northern part as well as at the southern part, as you can see from this map. And we will proceed further for qualitative and quantitative. We would like to see how is this screening patterns actually affect on this CRC cluster as compared to the non-cluster area. And we hope that by having these research, we able to integrate and collaborate with the Ministry of Health and come up with a pilot community in view of the cancer intervention study. And as a conclusion, improved awareness on the cancer screening update is very important, because before COVID-19, the screening is still low, and of course, because of the pandemic, is coming down and down. And the innovative strategy, and we need to start a pilot community trial for the cancer screening update. And we hope that a collaboration and integration is actually very important in view of for the cancer screening program. With that, thank you.